Elbow stiffness. Kamal Gokus. Associate Professor. Tashkent University Alanya Research and Practice Center. This video was produced from the book source that was shown below. Boyer Martin I. 2014. Aus Comprehensive Orthopedic Review 2. American Academy of Orthopedic Surgeons. Acknowledgement. We would like to acknowledge the editor Boyer Martin I and chapter author Anand M. Murthy, in preparing the text of this chapter in the previous edition. Citation. Boyer Martin I. 2014. Aus Comprehensive Orthopedic Review 2. American Academy of Orthopedic Surgeons. Overview. Most activities of daily living require elbow range of motion, ROM, arcs comprising 100 degrees, 30 degrees to 130 degrees, of flexion/extension and 100 degrees, 50 degrees/50 degrees, of pronation/supination. Flexion and supination loss cause more disability than extension and pronation loss. Epidemiology. Elbow stiffness is often associated with arthritis or trauma. Other causes. 1. Congenital arthrogryposis, radial head dislocation. 2. Cerebral palsy. 3. Head injury. 4. A burn that results in contracted skin scar or heterotopic ossification. Pathoanatomy. Intrinsic pathologic conditions. These include intra-articular fractures and malunions, joint incongruity, intra-articular loose bodies and adhesions, inflammatory arthropathy, osteochondritis dissecans, post-traumatic arthritis, osteoarthritis, and osteonecrosis. Extrinsic pathologic conditions. These include heterotopic ossification, skin conditions such as scar after a burn, muscle conditions such as myositis ossificans, capsular fibrosis/adhesions, and postoperative hardware impingement. Evaluation. History. 1. Duration of the elbow contracture. 2. Initial injury. 3. Previous surgical procedures. 4. Trials of splinting, therapy, or injections. 5. Complications of surgery. 6. The patient's work, life demands, and goals. Physical examination. 1. Function of the upper extremity, shoulder, wrist, and hand, should be assessed. 2. The soft tissue surrounding the elbow should be examined for previous skin incisions, scar, or infection. Evaluation. 3. Range of motion, should be assessed. Active and passive flexion, extension, supination, and pronation should be evaluated. The contralateral elbow should be examined for comparison. If the elbow has less than 90 degrees to 100 degrees of flexion, the posterior bundle of the medial collateral ligament, MCL, is contracted and must be released to restore flexion. Pain should be assessed during the mid-arc or at the terminal ends of motion. Mid-arc ROM pain is more common with the intrinsic disease. Evaluation. 4. Neurovascular examination. The ulnar nerve is of utmost importance because of its anatomic proximity to the elbow. The posterior bundle of the MCF forms the floor of the cubital tunnel, along the course of the ulnar nerve. Electromyography/nerve conduction velocity studies should be performed if any question about neurologic dysfunction exists. An assessment for ulnar nerve subluxation should be performed. Subluxation of the nerve is a relative contraindication for an arthroscopic procedure secondary to possible iatrogenic nerve injury. Evaluation. Imaging. 1. Radiographs should always be obtained. AP, lateral, and oblique radiographs are standard, with serial radiography as a follow-up when heterotopic ossification is present. The primary bony landmarks include the ulnar humeral joint, coronoid process, radial head, capitellum, radiocapitellar joint, olecranon tip, coronoid/olecranon foci, and trochlear ridge. 2. CT is helpful when assessing for malunion architecture and the location and pattern of osteophytes and/or loose bodies. Three-dimensional CT is used to check for heterotopic ossification. CT is not necessary when the stiffness is entirely soft tissue related. If any joint incongruity or abnormal bony anatomy is present, however, CT is beneficial. 3. MRI can be used to evaluate ligaments and tendons, but it is rarely indicated. Classification. Contractures can be classified as intrinsic, extrinsic, or mixed type. B. Intrinsic contracture. The primary cause of stiffness is related to intra-articular pathology. Common causes include intra-articular fracture malunion, joint incongruity, acquired or congenital, inflammatory arthropathy, osteochondritis dissecans, and post-traumatic arthritis or osteoarthritis, in which intrinsic the disease leads to the loss of articular cartilage and the formation of marginal osteophytes, at the coronoid and olecranon tips and fossae, that can limit motion. See extrinsic contracture. The primary cause of stiffness is outside the elbow joint. Common causes are heterotopic ossification, skin conditions such as eschar after a burn, muscle conditions such as myositis ossificans, and capsular contracture, which commonly complicates both simple and complex elbow injuries. Classification. D. Mixed type contracture 1. This is the most common type. It includes osteoarthritis and post-traumatic contractures. 2. Late sequelae of an intrinsic pathologic condition can lead to extrinsic stiffness. Treatment. A. Non-surgical treatment. 1. Non-surgical treatment may be attempted in virtually all patients with elbow stiffness in whom the treatment described below will not worsen the condition. 2. Non-surgical treatment includes the following. A. Physical therapy, active and passive ROM, and NSAIDs for 6 to 12 weeks. B. Intra-articular corticosteroid injections. C. Splinting/ROM regimen. Dynamic splinting. Progressive static stretch. Turnbuckle orthosis, adjustable static type. A 21-hour program of alternate flexion/extension exercises. B. Surgical treatment. 1. Indications. A. Extrinsic contractures. Surgical release is ideally indicated for extrinsic contractures when the joint surface is congruous and normal joint architecture is maintained. B. Intrinsic contractures. Surgical release can be helpful for some contractures of intrinsic origin, such as osteoarthritis, once the joint surface is altered or incongruous. However, the results are much less predictable. C. A patient in whom a course of non-surgical treatment has failed. D. A patient who will be compliant with postoperative therapy. E. Heterotopic ossification. This can be resected once it is mature, as evidenced by well-corticalized margins of the new bone and a lack of changes on serial radiographs. Contraindications. A. Intra-articular ankylosed elbow. B. A neurologic elbow disorder. C. Charcot elbow. D. A deficient skin envelope, may need a rotational flap. E. Post-traumatic arthritis. F. Surgical release rarely is indicated for mild contractures, less than 40 degrees, or for cases with severe articular incongruity. Anesthesia. Surgery can be performed with regional alone, or general alone. See surgical approaches and procedures. 1. Arthroscopic capsular release/osteocapsular arthroplasty. A. Indications. This procedure is indicated for patients with arthritis or extrinsic capsular contractures. B. Procedure. Arthroscopic capsular release is a technically demanding procedure because of the small joint space and the close proximity of neurovascular structures. Posterior compartment, olecranon tip/fossa osteophytes and loose bodies are debrided. Posterior capsular release is performed. Debridement/suction is avoided medially to protect the ulnar nerve. Anterior compartment, coronoid tip/fossa osteophytes and radial fossa osteophytes are debrided and loose bodies are removed. Anterior capsulotomy/capsulectomy is performed. To improve visualization, accessory portals and retractors should be used judiciously. The neurovascular structures must be protected. The radial nerve is at greatest risk, followed by the ulnar and median nerves. Strategies to protect the neurovascular structures include insufflating the joint before establishing the portals, using proximally positioned medial and lateral portals in the anterior compartment, keeping the elbow flexed when establishing anterior portals, using retractors during debridement and capsulotomy, releasing the anterior capsule proximally, and avoiding cautery and shavers in the posterior medial gutter, ulnar nerve. Open lateral column, Mori, approach, Figure 1. Indications: extrinsic and or intrinsic contracture that has failed non-surgical treatment. Procedure: the lateral column approach can be performed through a posterior or lateral skin incision. The extensor carpi radialis longus/brachioradialis muscles are elevated anteriorly and the triceps muscle is elevated posteriorly. Figure 1. The illustration shows the lateral column approach for treating stiffness of the elbow. This approach is used to address the anterior and posterior aspects of the joint by exposing the capsule through the anterior interval, which consists of the distal fibers of the brachioradialis and the extensor carpi radialis longus, ECRL. The posterior interval simply consists of elevating the lateral margin of the triceps from the posterior aspect of the lateral column. ECRB equals extensor carpi radialis brevis. Reproduced with permission from the Mayo Foundation for Medical Education and Research, Rochester, Minnesota. The brachialis muscle is mobilized off the anterior capsule. The anterior capsule is released and excised. The coronoid tip/fossa are debrided. The olecranon tip/fossa are decompressed. The radiocapitellar joint is debrided. The posterior capsule is released/excised. Open medial over the top. Hotchkiss, approach, Figure 2. Indications: this approach is indicated for patients with extrinsic contractures, associated MCA calcification, ulnar neuropathy, and or preoperative flexion limited to 90 degrees to 100 degrees. Procedure: the ulnar nerve is decompressed or transposed. The posterior band of the MCA and or the capsule is released to increase flexion. Figure 2. The illustration depicts the open medial approach. The capsule is exposed by reflecting the pronator teres from the anterior aspect of the capsule. The ulnar nerve is identified and protected. Reproduced with permission from the Mayo Foundation for Medical Education and Research, Rochester, Minnesota. The surgeon should work anterior to the flexor/pronator mass and may need to release proximally to assess the anterior capsule. The anterior capsule is excised. The coronoid tip/fossa are debrided. 4. Combined approach. Indications: cases of significant elbow stiffness in which a unilateral approach is inadequate for complete elbow release. Cases in which previous hardware removal is necessary. Figure 2. The illustration depicts the open medial approach. The capsule is exposed by reflecting the pronator teres from the anterior aspect of the capsule. The ulnar nerve is identified and protected. Reproduced with permission from the Mayo Foundation for Medical Education and Research, Rochester, Minnesota. Combined approach. Indications: cases of significant elbow stiffness in which a unilateral approach is inadequate for complete elbow release. Cases in which previous hardware removal is necessary. Procedure: a posterior skin incision, with medial and lateral skin flaps, is made. If the elbow has less than 90 degrees to 100 degrees of flexion, the posteromedial band of the MCA and the posterior capsule are released to restore flexion. Ulnar nerve decompression or transposition should be considered. Interposition arthroplasty. Interposition arthroplasty is a procedure in which the distal humerus is resurfaced with biological material. An external fixator often is used to distract the joint and provide stability in the immediate postoperative period. Indications: the procedure is considered for intrinsic contractures in young patients, 20 to 50 years, in whom the anatomic architecture of the distal humerus and proximal ulna are relatively preserved. Procedure: a hinged external fixator is used for distraction and to maintain stability. Interposition. Interpositional arthroplasty grafts may include autologous fascia, dermis, allograft Achilles tendon, dermal allografts, and xenografts. The collateral is reconstructed if necessary. Total elbow arthroplasty. Indications: total elbow arthroplasty is indicated only for older, low-demand individuals with intrinsic disease. The procedure has a high failure rate in young, active individuals with post-traumatic arthritis. Following total elbow arthroplasty, patients have a permanent 5-pound lifting restriction. Complications: 1. Postoperative heterotopic ossification. Prophylactic treatment with indomethacin or low-dose radiotherapy should be considered. 2. Neurovascular compromise. The ulnar nerve is at greatest risk and usually is transposed anteriorly. 3. Ulnar neuropraxia is often associated with an acute increase in flexion when preoperative flexion is limited to 90 degrees to 100 degrees and the ulnar nerve has not been decompressed. 4. Superficial infections. 5. Prolonged drainage/seroma is common with open releases. 6. Recurrent contracture. 7. Skin/wound healing problems. Rehabilitation. 1. Continuous passive motion, CPM, through full ROM, under regional anesthesia. The efficacy of CPM is debated, however. To be used for 3 to 6 weeks if maintaining or improving ROM. 2. Active and active-assisted ROM therapy. To be used for 3 to 6 months to maintain and increase range of motion. 3. Compressive elbow stockings to pump out edema. To be used for 3 to 6 weeks to decrease postoperative swelling. 4. Compressive cooling elbow wraps. To be used for 3 to 6 weeks to decrease postoperative swelling and inflammation. 5. Nighttime extension splinting. To be used for a minimum of 6 weeks to maintain elbow extension. 6. Transition to dynamic or static progressive stretch splinting. Instituted at 6 weeks postoperatively to increase ROM in both flexion and extension. Top testing facts. Most activities of daily living require elbow ROM arcs comprising 100 degrees, 30 degrees to 130 degrees, of flexion/extension and 100 degrees, 50 degrees/50 degrees, of pronation/supination. CT scans are helpful to understand the anatomy of intrinsic elbow contractures with changes in the bony architecture. Surgical release is ideally indicated for extrinsic contractures when the joint surface is congruous and normal joint architecture is maintained. Arthroscopic procedures require careful portal placement to minimize the risk of nerve injury. The radial nerve is at greatest risk, followed by the ulnar and median nerves. Open surgical approaches include the lateral column and the medial over-the-top approaches. Either approach or a combined approach can be performed through a single posterior incision. Top testing facts. The medial approach is indicated for patients with extrinsic contractures, associated MCA calcification, and ulnar neuropathy. If the elbow has less than 90 degrees to 100 degrees of flexion, the posteromedial band of the MCA and the posterior capsule should be released to restore flexion. Ulnar nerve decompression or transposition should be considered. To prevent postoperative heterotopic ossification, prophylactic treatment with indomethacin or low-dose radiotherapy should be considered. Progressive static stretch or dynamic splinting should be considered at 6 weeks after surgery for residual stiffness. This video was produced from the book source that was shown below. Boyer Martin I. 2014. Aus Comprehensive Orthopedic Review 2. American Academy of Orthopedic Surgeons. Acknowledgement. We would like to acknowledge the editor Boyer Martin I and chapter author Anand M. Murthy, in preparing the text of this chapter in the previous edition. Citation. Boyer Martin I. 2014. Aus Comprehensive Orthopedic Review 2. American Academy of Orthopedic Surgeons. Thank you for watching my video. Please subscribe to my YouTube channel.